When you think of visiting a hospital, what feelings arise? Is it sadness or fear, sometimes joy, and maybe even anger? Stay with us as we talk with two hospital chaplains who help folks in the hospital as patients and those visiting on this edition of Austin Faith Dialogue.
Austin Faith Dialogue, at the crossroads of religion and life. A series highlighting the cultural and social interactions between the worshiping and religious communities in and around the capital city. Austin Faith Dialogue is brought to you by the Austin Metropolitan Ministries in cooperation with KXAN. Join us now in Austin Faith Dialogue.
Hello, my name is Shane Whistler, your host for this edition of Austin Faith Dialogue. And today we're talking about hospital chaplaincy, and with us as guests are the Reverend Jim Denham, who's the director of at Seton for chaplain services, and also Reverend Ann Rosewall, who is the director at Austin Diagnostic Medical Center and their pastoral care department. So we are very glad to have you with us today to talk about something that makes some people nervous, visiting the hospital. And you two are there every day, just about all day long, and sometimes all night long. And but for the first question, I want to pose the situation I'm sure you run into. You meet someone new in the community outside the hospital, and they approach you and say, "You're a hospital chaplain." And say, "Jim, why did you become a hospital chaplain?"
Well, a lot of times you get a negative reaction about chaplaincy because all they know about chaplaincy is what they see on TV or the movie, and that's usually the chaplain walking the person on death row or delivering the bad news. And a lot of times, as a chaplain, when you're visiting patients, they're frightened when you walk in the room, and I have to explain to them I'm just making a visit, I'm just making rounds, trying to relax them. Chaplaincy is a wide range of things. Certainly we do deal with death. We do deal with some very sad situations. But a lot of it's trying to help people understand their illness.
Mm-hmm. Good. Ann, what would you say if someone asked you, why did you become a chaplain, and what are some of the things you do?
Sometimes I think I'm naturally drawn to crisis situations. That there are times when people are having a physical crisis, and that brings on a spiritual crisis. And having a call to ministry to be there when someone is wrestling with, what does my faith mean for me now? Now that I'm facing a terminal illness or a broken bone or a surgery, how is my faith going to help me? Is my faith getting in the way? Do I have any faith at all? All those questions come up. And I see it as my role to help draw them out and find out what strengths they already have, not to necessarily bring an answer, though that would be a nice thing to do now and then, but to help draw them out in terms of finding meaning in what's happening to them at the time.
Mm-hmm. There's also, as Jim mentioned, you first have to cross a hurdle of what's expected when they realize you two are dressed as you would be at the hospital. Mm-hmm. So it's not as obvious immediately that you're the chaplain. But what do you say when you enter a room, Jim, for instance, to say that when you're the chaplain and they maybe move back, what are the first things you tell them in your visit?
Well, there are different things. Sometimes the TV is on, and I always point to it and say, am I interrupting?
Uh-huh.
And they can say, well, actually, yes. I've been watching this movie for 2 hours, and it'll be over in about 15 minutes, and I really do want to watch the end of it. And then I say, well, I'll come back later. I'm the chaplain, just making rounds. But most of the time, they will turn the TV down or turn it off. Most of the times, they are open to the presence of a chaplain. Many people, when they're in the hospital, are asking, why me? Did I do something wrong? Is God mad at me? Or they're mad at God, and you're the man of God or the woman of God, and they're going to give you their 2 cents worth, and they want to know, where's the spirituality of all of this?
Right.
So it can be a lot of fun, but it's you have to stay on edge with it.
Mm-hmm. And you talked about the physical crisis bringing on the spiritual crisis. What does that mean? We use the word spiritual a lot, and I think Jim already alluded to some of that. What does it mean to be in a spiritual crisis to you?
I think it's very different from wrestling with your religion. I think a spiritual crisis is when you are trying to identify the meaning in your own life and the meaning in your present situation. Where is it that you get your strength to get through a crisis? Is it something that's inside of you? Is it something that's outside of you that you need to draw on? Something you need to rediscover within yourself? Many people have practices of spirituality that they don't identify as spirituality. We have routines in our lives, whether it's waking up with certain thoughts or a practice of meditation, a practice of prayer, certain rituals that have become very centering, a way to find peace in your life or purpose in your life. All those things together contribute to what spirituality would be, which is different for each person.
Well, it's talking about how people perceive chaplains. Mostly, as Jim described, you see them death row, all these difficult either moment of death situations or crisis situations, and it's usually negative or non-existent. I watch the two hour-long hospital dramas on television. I keep saying, when are they going to write in the chaplain's part? Because I think of people like you every day in the hospital. Is it unusual? Perhaps County Hospital in Chicago or Chicago Hope fictitiously don't have chaplains on staff. You two are full-time at your respective hospitals. Is it unusual for hospitals to have chaplains nowadays? And how many full-time folks in the Seton medical network?
Most hospitals will have a chaplaincy program of some kind, particularly if they're religious-based. Seton is a Catholic hospital, so it has that basis. But county hospitals, city-run hospitals will often try to find some way to have chaplaincy involved. Either area ministers become volunteers and create a chaplaincy program. When I was pastoring a church over in East Texas, there was no chaplain, but the ministers of the community would be on call for a week and would go to the hospital each day and try to make rounds. The standard of care was not very good in some ways, but most communities recognize that people are wanting that on some level.
And how about staff? You've been with Seton for a number of years. How many full-time people work within the chaplain services department?
Well, right now we have 5 hospitals, and to cover those 5 at the moment, we have 9 full-time people and about 20 part-time people. Some just work one shift or one day a month, but we have a large group of people to call on because we both have to deal with the scenario of 24-hour day coverage, and that can be very difficult to maintain that. One of the real struggles we have within the profession is burnout. It isn't that you don't like your work, but you do like to have a day off.
I can see that. That's why, as many ministers do, they've served a term as a chaplain intern. And during my experience, working with both of you, as a matter of fact, gained a tremendous respect for anyone who could take on that specialized calling for a full time, for their ministry career. Also gained a lot of respect for the floor nurses, as well as many other hospital staff. I did want to move into the hospital staff too, because people, certainly the patient is the person who needs the care and the focus is there. But for chaplains there in the hospital all day long and for staff, are there instances when you serve as the chaplain to the staff? Ann?
Absolutely. I see my patients and their families as my evolving congregation. Folks are generally in the hospital 3 days and head on home, and the staff is my permanent congregation. It's essential to establish relationships of trust so that we can function as a team to care for our patients. The staff does accept the chaplain as a member of the medical team, which has been of great benefit. To receive a call from a physician in the operating room saying, would you meet the family in the waiting room and stay with them until I can come out? In the event that it is bad news, to provide that support. And then I do follow up with the physician, do follow up with the nurse, because often, especially where our Our hospital, Austin Diagnostic Medical Center, is affiliated with the Austin Diagnostic Clinic, which has been in Austin for over 40 years. The physicians have long-term relationships with the patients, and these are personal losses sometimes, and frustration that we have human limits as to what we can do medically. A lot of support for all levels of the staff.
Good. I know several instances that they are glad you're there for them as well. You mentioned being called in by a physician, and I know that sometimes people, I don't know what the group is called sometimes, that are called to assemble to discuss with the family, with the physician, and also have a chaplain in to, I don't know if it's called a consult, if you could help me.
Consultation.
Consultation. What are those like, and is it unusual for a chaplain to be in those conversations?
It's not at all unusual. The consultation will be because there's a dilemma of some kind. The patient doesn't have adequate support at home, or they are problematic in some way in the hospital. We're trying to figure out what is the best care. Sometimes the family is unhappy. Sometimes the patient is unhappy. And there are different parts of that that have to be dealt with. The chaplain is involved to try to understand the issue and try to talk to the family members, to the physician sometimes. Sometimes there has been wrong information or misinformation, and the chaplain is often perceived as something of a neutral person. This is a person that will be fair, if you will, hearing the different points of view and then trying to help to resolve it.
I notice when families are waiting to hear news about a patient, or the patient receiving information from the doctor, that's such a high anxiety moment. They're not able to hear, or they're not able to remember. And it seems like it'd be very helpful to have a chaplain there, if the family is open to that, to help listen, help digest those things, and let them sink in and be able to tell them again.
It's helpful to be with the family and the patient ahead of time. Then when the physician or the nurse or the technician comes in, to help the patient remember what their questions were to begin with.
And you talked about drawing people out, and we're going to have a short break in just a moment, but I wanted to pursue that further. And also, in our second segment, talk a little bit about whether people are visiting from a particular religious community. They're called within their religious communities to go be visitors in the hospital, try to give them some guidelines about how to visit. And also from the patient side, I see so many times patients are trying to be the host or hostess in their own room, and they're the patient. So we want to think about those things, and offer people some guidelines, because we don't learn this in school, and it's often assumed. I think it's my feeling that people assume you'll just know what to do, but it's not so easy, as your careers will testify. So please stay with us at Austin Faith Dialogue as we pursue the question of what it's like to be in the hospital and what it's like to care for those receiving care. Hello, I'm Shane Whistler, your host for this edition of Austin Faith Dialogue. Thank you for being with us today as we talk about hospital chaplaincy. And with us today are two hospital chaplains and directors at their respective hospitals of the pastoral care, Reverend Ann Rosewall at Austin Diagnostic Medical Center, Director of Pastoral Care, and Jim Denham, also a minister who's Director at Seton Hospitals, of which there are 5 now in the Austin area with Seton Care. But to continue our conversation, Ann, you mentioned early on about drawing people out. What does that look like, and how do you do that?
As a member of the medical team, I have access to the patient's chart. So I have a little bit of background before I go into a patient's room. I know their name, I know where they're from, what their diagnosis is, and whatever information the nurse or the physician has given to me. As I walk into the room, I kind of do a visual check. Does this person have a lot of flowers in their room, or cards, or maybe a Bible, or some objects that seem to be significant to them? I introduce myself to make it clear who I am, that I'm not somebody that's going to poke them or do anything intrusive. And then I offer an invitation. I ask them about, how their spiritual health is. So often, others, even from their own faith community who are visiting, are not comfortable with asking spiritual questions. And I'm fairly assertive about getting in there and asking the patients, what are your spiritual issues right now? And I might draw on those things that I see in the room. Oh, I see you have a lot of people thinking about you. Or I see your Bible sitting here. What scriptures have been meaningful to you? And in that way, asking, they'll say, oh, I have a whole, people across the country are praying for me. We hear a lot. And I'll ask them, have you had a chance to pray? What are you praying about? Those kinds of things, to get right at it. I had a very significant experience early on in my career. I was out in the hallway and heard 2 women talking. And they said, wasn't it nice of Pastor to come by and see Bob while he's in the hospital? Maybe next time he'll talk about God. And that struck me, that they're, come in, talk about the weather or whatever, how important it is as a representative of the religious community to talk about faith and spirituality.
Mm-hmm. That's a good point. What would you like to continue, and maybe a suggestion to some pastors or religious leaders of different faiths? What because it's seminary, unless they've been trained in, asked to have a unit of what we call clinical pastoral education, which is learning what it's like to be a chaplain in the hospital. Right. Not all ministers are required to do that, or leaders of different faiths. So what would you say as a tip or two, both of you, what would you like to tell the religious leaders of the community visiting the hospital as a few tips? I
would say call before you come. Not everyone wants to see their pastor while they're in the hospital. Some people are having tests, and maybe Monday's not a good day for someone to come and visit, but Tuesday would be really nice. So to call and ask permission, to check with the nurse before you go in to visit, kind of checking again, is this an appropriate time to come? To offer a sense of continuity. I'm not only coming to see you in the hospital today, but I remember seeing you at the potluck last Sunday, and I'm looking forward to seeing you at worship again. Those kinds of things. To bring out the story of faith.
Right. Jim, would you have anything in addition?
Well, there are all kinds of things you learn, and unfortunately some of them you learn the wrong way, but one of them is not to be too nosy. They may not want to tell you all about what's wrong with them and why they're there. And even though people in the congregation may be asking the pastor, well, why is this particular member in the church, they may not feel comfortable with everybody in the church hearing their various body parts discussed. Another thing is, and which is the flip side of that, is the whole issue of confidentiality. And sometimes people don't want to tell people in the church why they're in the hospital. It's none of their business. Right. And it is a difficult thing, and we struggle with that as chaplains all the time, of our being having access to the medical charts, and yet we are not at liberty to talk about what we know.
That's right.
Another issue that comes up often is that ministers sometimes try to do what they do in the pulpit at the bedside, and people really don't need a sermon. They need compassion, and they need some kindness and gentleness. Sometimes not a lot needs to be said at all. Simply to know a very brief visit, and I mean 2 or 3 minutes, literally by the clock. 2 or 3 minutes can be an extremely meaningful visit. They're tired. They've just been cut open from here to here. They've had surgery. They don't want to entertain. They may have been able to entertain before the surgery, but after the surgery, they don't feel like it.
Right.
So a brief visit.
Those are excellent points. I appreciate you all sharing those. I wish sometimes, from a Christian's perspective, that the Gospels had described more about Jesus listening, because I'm certain in my faith perspective that Jesus was a superb listener. And we think of preaching and ministers in hospitals always speaking. It's like it's time to listen, especially in the hospital. I think you two have highlighted. And as I mentioned, the three of us happen to be from a Christian tradition, and I haven't even mentioned your particular labels of denominational affiliation, but Baptist and Presbyterian traditions are represented. But can you say a word about people who maybe consider themselves agnostic, even atheist, or we have a wonderful diversity in Austin, tremendous diversity of Jewish tradition, Hindu, Muslim, Buddhist. Should they be worried or self-conscious that this Christian person is coming in their room?
Not if it's a professional chaplain, because professional chaplains are trained to deal with people of other faiths. Every chaplain has to come out of some kind of faith background, but you are trained to listen to people and try to find out what they believe, try to, if you will, crawl into their faith house, see what's holding them up in their crisis, figure out how to help them find resources to support them. Sometimes people are not open to the chaplain at all. I've been asked to leave rooms within seconds of entering simply because I said I'm a chaplain. And I respect that. I leave immediately. That's fine. But most people are at least to the point where they'll say, well, I'm not a Christian. And I'll say, well, that's fine. Do you have a particular faith? Do you have a clergy that I can contact for you? Do they know you're here? And sometimes they're quite surprised because that isn't what they expect you to do.
Right. That's good. It's good for people to know. In a few minutes we have remaining, I'd like to ask you to offer a few tips about visiting those who are in the hospital. You've had some comments towards pastors and other religious leaders, but what about someone who's visiting either a friend, a coworker, or they're asked by the church to go visit Martha who's in the hospital? What would you say to them if they're anxious a little bit? They want to, but they're a little anxious about visiting.
Bottom line is to meet people where they are. That if you're visiting a friend or a coworker or someone else in your faith community, you don't know what you're going to find on the other side of that door. People who are in crisis can respond in a variety of ways. Some get immediately very depressed, and some become cheerleaders. And you know that they've got this critical thing going on. You walk in the door, and all of a sudden you find this person who's saying, I'm going to fight it, I'm going to do this, I'm going to draw on that, and they're fired up. As a visitor, it's very tempting to kind of bring them down. They're saying, like, maybe she's in denial, that this person is too happy for this kind of information. Inclination is to bring them down. My word of advice would be to meet them where they are and become part of the cheering section. Conversely, if someone is in the depths of despair, to sit there with them and say, yeah, this is an awful situation. I wish I knew what to say. It's okay to say, I don't know what to say.
To be honest.
Exactly.
Jim, would you add to that? And it sounds like, for one, don't be an armchair psychologist, and to meet them where they
Well,
are.
don't make comparisons.
I'm reminded of the scene in Jaws where they're comparing shark scars. And that's what people do often, I think, when they visit in the hospital. It's like, oh, you had that surgery. Well, I remember, and and it's not about the visitor, it's about the patient. And what would you say?
And it isn't about somebody else. And, you know, they'll say, well, my neighbor had that, and, oh, it was horrible, just horrible. And so then you get them worried, but that isn't their experience. Or it was wonderful, and here this person's in pain, and they're thinking, well, what's wrong with me because everybody else gets well so fast and I'm not. So avoiding comparisons. People want to know that you care, but frankly, some people are not very good hospital visitors, and as I mentioned before, they stay too long. They stay entirely too long. Sometimes they'll ask you to stay. Well, if they're asking you to stay, well, that's fine. But a lot of times you'll say, well, I've got to go. They'll, well, that's fine. I mean, they're ready for that. One of the frustrations is that at different hospitals, it's very difficult to find a place to park. So here the visitor has gone through all the trouble to find a place to park. They've weaved their way through the building. They find the elevators. They finally get up to your room. They plop down. They're there to stay, and they shouldn't. I know it took them a long time to get there, but they need to make it a quick visit.
So we wouldn't want to put anything hard and fast, but with the size of Austin and the hospital usage, it seems like maybe the visit ought to be about half as long as it took to find the parking spot, depending on the person and the relationship.
I think another thing has to do with infection.
Washing your hands is the thing I remember. We have just a minute, but please tell us about those clinical concerns.
Well, when you are, many times you are bringing germs into the hospital, and there are precautions. You need to wash your hands before you go into the room. Certainly, if you're sick, don't go. I mean, call them on the phone or send them a card, send flowers. But your medical condition is certainly to be considered as well as theirs.
Right. Ann, any closing thought in just a second or two?
To go and visit, if you can. That is a mandate of most faith communities, to visit the sick.
Good. Well, you all have helped us in that and having a little sense of what to do and how to do it. I appreciate your work. Thank you for joining us on this edition of Austin Faith Dialogue. Until next time, peace be with you.